Okay, so it looks like a lot of you have uploaded study sheet examples. I'll show you mine too, but we'll look at a couple. I like to see enlargement, ethnicity. Okay, that looks good. So different side effects there. Um, my suggestion, because you make the sheets hover as beneficial to you, but my suggestion is to try to, you could use that for studying and say, okay, this is potential things that happen, which medications are the ones that might cause that.
Where were you able to put that? Because I can't find, I asked earlier where we put our answers, and everywhere that I go, I can't submit mine on Blackboard.
Okay, so this was, I'm sorry, I didn't see that question. This, you're supposed to put it right here. This is a Dropbox. Upload the CHF medication and answers on our week, on our content week for cardiovascular part 2.
Okay.
So I'll show you what I did. These are good. This all I to see is that you're thinking about different things that could occur. And in fact, I think there's some, as I'm looking at this, that I probably could have done mine, added some symptoms to mine too. So you might want to look at other people's work and be sure that you've gotten all the potential effects. So I color coded mine just so that I can focus in on what causes what. So I have hydrochlorothiazide, furosemides, spironolactone, and digoxin, because those were the main meds we talked about for congestive heart failure. And I have my orthostatic hypotension for the diuretics. I added like the headache vision change for digoxin, the increased testosterone, maybe facial hair for the women, but then I did not put, which I saw, the ototoxicity, which I should put for furosemide because that is potential issue there. Heart, those potassium level heart dysrhythmias is one of the big things we have to worry about. So low potassium in general causes slower heart dysrhythmias, so hydrochlorothiazide and furosemide. High potassium is actually more dangerous in terms of cardiac effects. And high potassium can lead to ventricular fibrillation and ventricular tachycardia. So that's spironolactone's potential. Digoxin doesn't cause change in potassium, but we have to remember that a low potassium increases risk of toxicity. So I'll put mine up in the same area so you can look at mine too. Extremities, gout symptoms, muscle weakness and cramps I have there because that's commonly experienced with any potassium change. Remember, this is extremely important to include those early signs of toxicity that affect appetite, nausea, and vomiting. So take a look at other people's too to be sure that you are putting as much as possible on your own map. So now we will turn to and begin talking. We'll finish the lipid medications and start angina before a lunch break. So all of this information is on the PowerPoint listed coronary artery disease. So atherosclerosis, coronary artery disease, angina, and MI. Having cholesterol buildup in your blood vessels is a huge risk factor for angina and myocardial infarction. So I always say to everybody when we start this lecture that now that you're entering the medical nursing hospital community, you have to pronounce it, you have to pronounce angina like this community does. Because people who work in healthcare do not pronounce it angina. That's the way the community says it. So now you have to you have to say it like that now. Um, so the biggest risk is related to hypertension is one of them, and the other is too much cholesterol, because too much cholesterol can cause that plaque to develop in the blood vessel, which will narrow the blood vessel and make it harder to get blood to essential tissues. And in the heart, that means it's harder to get blood to heart muscle. And if that occurs, then it's potential that some of the heart muscle will not get enough oxygen, and that can lead to areas of infarction or dead tissue. So cholesterol in and of itself, or lipids in and of itself, is not bad. We need cholesterol and fat in our diet for fuel, as well as, in particular with cholesterol, maintenance of all of our cell membranes, because they're made of cholesterol and protein, as well as production of hormones that have a cholesterol component to them, or steroid hormones. Some of those steroids hormones are growth hormone, sex hormones, estrogen, progesterone, and testosterone, cortisol, which we talked about. Those are all hormones that are made from cholesterol. So it's not like we don't need it. The problem is that people will eat too much of it. Most of the time, there are certain genetic disorders that can lead to an elevated cholesterol level, but most of the time, the reason why people have elevated cholesterol is related to their dietary intake. So, and as we have done for each section, you have to understand how the body uses cholesterol and and produces it in order to understand the medication targets. So when a person eats fat or cholesterol, that goes down into their stomach and into the first part of the small intestine. And there is communication between the first part of the small intestine and the liver. We talked about that before, because that was why there's a first pass effect. There's a relationship between the first part of the small intestine and the liver that's called the portal circulation, which is, it's very important. It helps detoxify the things that we ingest, like alcohol and drugs, and it is part of how we process triglycerides and cholesterol. What we eat in terms of fat and cholesterol is absorbed into the portal circulation, into the veins, and taken to the liver first so that it can be packaged as different types of molecules that have a certain percentage of protein and a certain percentage of triglyceride and a certain percentage of cholesterol. So the smallest ones are chylomicrons, and those actually contain mostly triglycerides or fatty acids. Then we have very low density lipoproteins, and high density lipoproteins. The liver makes these, all of them really, and that circulates in the bloodstream to be used by the body for the things that it needs. If there's more cholesterol than we need, then the body uses HDL, sort of like a Roomba. It kind of picks up the extra cholesterol and brings it back to the liver to be processed. The actual creation of these products are dependent on certain enzymes. To create the packaged triglyceride, we need a lipolipase enzyme. To create the VLDL, LDL especially, and HDL, we need HMG-CoA reductase, which is an enzyme that helps produce these cholesterol and protein molecules. So the medication targets are really changing the activity of those enzymes, so we produce less of those products. So HDL transports cholesterol back to the liver from the tissues to be recycled. LDL transports cholesterol from the liver to the tissues for use. So if we then end up with too much cholesterol, so we use the cholesterol, the body used what it could, and then the HDL, our little vacuum Roombas, brought the excess back to the liver, there's only so much we can shove into the liver. If there's still extra cholesterol roaming around the blood vessels, that gets eaten up by our white blood cells. They try to digest that to get rid of it, and that ends up forming plaques. It's actually just a mix of white blood cells and cholesterol and inflammation that create plaques. And so now I've narrowed this tube so it's harder to get blood through. The other issue is sometimes this narrowing activates platelets, so it increases the production of blood clots. So I have increased my risk for having a clot or blocking my complete vessel to my legs, to my brain, causing a stroke, to my heart, causing a heart attack. So people should regularly have, at different ages, their cholesterol levels checked to be sure that they are within the normal range. For total cholesterol is usually thought of to be less than 200. Usually people will have their total cholesterol checked and then they will break it down into the types of cholesterols. Do we want the LDL between 130 and 100 for most people? If they have a history of diabetes or have had a heart attack or something, we want it even less than 100 if we can. HDL, that good cholesterol, we would like to be 50 or greater. So we always give people a chance, and it would be best if the person could change their lifestyle in order to be able to improve their cholesterol levels. And the way to do that, of course, is to change your dietary intake of fats and cholesterol and reduce your weight. Increasing fiber helps bind excess cholesterol in your intestines instead of being absorbed into your system. Obviously, tobacco products increase vasoconstriction and contribute to atherosclerosis, so anything anyone does to reduce smoking is good. And exercise has been shown one of the only ways that we can naturally increase the amount of HDLs in our body. However, if the person is at very, very high risk of developing a heart attack, or we've given them a chance to do lifestyle modification and it's either not working, they're not able to adhere to it, then it's recommended to use medications. And as I said earlier, those medications are either to block HMG-CoA reductase, which will change the synthesis of lipids in the liver, or the lipolipase enzyme to change the synthesis of triglycerides in the liver. Those are the two classes of medications. HMG-CoA reductase inhibitors are the family of statins. Our prototype is Atorvastatin, which is Lipitor. That was the first one that was made. There are other statins, and so you might see them in other places, but Atorvastatin is the one that will be on our exam. Fibric acid agents, or those agents that change the lipolipase protein, are best used to lower triglycerides, but they will have some effect on cholesterol. And our prototype medication is gemfibrozole. Even that was the first one that was made. It is not prescribed as much anymore. Fenofibrate is used much more than gemfibrozole, but because it was the first one, that's the one that's mentioned on ATI and in our textbook. The gold standard for cholesterol reduction is statin medications. They work the best. They decrease statin level by a lot. They decrease lipid level by a lot, 20 to 40%. And they also affect inflammation in the vessels and have been shown, even especially in diabetics, to decrease the chance of heart attack. So sometimes even diabetics who may have near normal cholesterol levels will be placed on atorvastatin as a protection against a cardiac event. So this medication could be used with or without food, taken with or without food. People take it at all times of the day. It's best to take it at night because the activity of the enzyme HMG-CoA reductase occurs most at night. Although you will see people take it at all times of the day, and it's not like it won't work. It's a pregnancy category X, so you cannot use it in pregnancy. And grapefruit juice changes the way this medication is processed. It makes it easier for the medication to become toxic. What was the blood pressure medication that we talked about that you can't have nifedipine with? Oh, well, there you go. I just gave the answer that you can't have with grapefruit juice. It's nifedipine, so never mind. Okay, atorvastatin side effects. So these are common but non-life-threatening. I mean, you could potentially put cataracts in adverse effects because that could change the person's vision, and it's not as common. But headache, fatigue, potential rash, GI upset, and then this muscle and joint pain. Not to be confused with one of the very bad adverse effects of atorvastatin, which is myopathy. So myopathy is breakdown of the muscles themselves. And that breakdown of muscle actually leads to kidney failure. It's a kind of kidney failure called rhabdomyolysis. So most people who start atorvastatin will have some degree of muscle and joint pain, and you have to distinguish those people that will go away with the people that are developing severe myopathy, which could potentially lead to kidney failure. So the way to do that, I mean, one is that usually the severity of pain for myopathy is much, 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 much higher. The pain is really bad. However, you never know between people and their pain tolerance levels, which is which. The way to know for sure is to do a blood test called a CPK, which is testing for the enzyme present in skeletal muscle. And that will be very, very high if the patient is actually having myopathy where the muscle is being broken down. If the patient complains of muscle and joint pain and the CPK is normal, it's possible they're just experiencing a side effect. It does usually go away with time. It could get better if they increase activity and stretching. And they could use like an over-the-counter pain medication. Given the patient's history, we're worried that they're going to have a cardiac event. Either they've had an MI already or they're at very high risk for an MI. What over-the-counter pain medication would you suggest? I'm seeing Scott is typing. So
It's Tylenol. That's just what I was thinking.
Yes.
Like anything else would be too problematic on kidneys.
So that's one of the reasons. There is another reason that is also extremely important why I wouldn't recommend ibuprofen for this patient. So I agree with the Tylenol for sure. I'm giving the people a chance to finish typing before I give the answer. It looked like people were typing and then they changed their mind, or right, it is Tylenol. It has to do with the difference between aspirin and Tylenol in terms of bleeding risk. So, and this is why I like to bring this up because it is in the common um, discussion of ibuprofen that ibuprofen increases bleeding risk. Remember, it does not increase bleeding risk. It does not have that relationship with platelets that aspirin has. Ibuprofen actually increases clot risk and it has an increased effect of MI and CVA. So the reason to avoid ibuprofen is its thrombotic effect. Oh yeah! Naproxen too. All of those NSAIDs, besides aspirin, have an increased risk of thrombotic event. So that is the biggest reason why somebody with a risk of MI or who's had an MI should avoid ibuprofen or naproxen because of that. They're actually recommended to use Tylenol instead. So remember, keep that in mind because people, and it's not your fault, it's because it's everywhere. You'll hear it from other teachers, you'll hear it from, I know a provider that likes people to hold ibuprofen prior to surgery because of bleeding risk. It does not increase bleeding risk. It does not have antiplatelet effects. A small percentage of patients will develop hepatotoxicity, but that's very tiny, and so it's not a reason to avoid Tylenol. And the people, when they first start atorvastatin, will be monitored for the liver function in the beginning. If the starting atorvastatin brings their liver enzymes up, they will be told to stop it, and the liver enzymes will return back to normal. So it's something that has to be monitored. If the patient's main problem is an elevation in triglycerides, or they are unable to take a statin because of liver problems, or maybe they are allergic to it, or some other reason, you could use gemfibrozole or a medication from the other family, which is those fibrates or fibrates that change the activity of the lipolipase enzyme. This medication has to be taken with food. It's not the gold standard because it doesn't decrease LDLs as much as the statins do, and it does not show a decrease in mortality from cardiovascular disease. So it would, bringing these numbers down, decrease cardiovascular events, but it doesn't change mortality, and atorvastatin does. So there are other things to worry about. GI side effects, same as nausea, vomiting, abdominal pain. There are the similar severe side effects, so we have to worry about myopathy and liver toxicity, and which is why gemfibrozole and atorvastatin are not taken together. You either take one or the other. It'd be better if you could take the statin, but if you take them both together, especially the risk of myopathy is very great. And the other issue is gallbladder disease. Because gallbladder disease changes the way people, or can change the way people process fat to block that lipolipase enzyme, can make gallbladder disease worse. So I'm just going to take a quick 5-minute break because I have to go to the bathroom really bad. So I'm going to snap off this, and then at 11:30 we'll come back and talk about, begin talking about angina. Okay, I'm back. I'm trying to increase my water intake, but all it does is make me have to pee all the time. Okay, so back to sharing the screen here. Can somebody tell me the difference between unstable and stable angina? Or can someone tell me what angina is? Or both? Or either? Chest pain?
Isn't the stable, it's more of a shortened duration versus the unstable is more of a chronic, longer lasting version?
Right, so the stable angina can be relieved by rest, and so would generally be over. You have the experience and then it goes away. Unstable angina is not relieved by rest. You're going to need medication, and it's difficult, especially in the beginning, to distinguish between unstable angina and actual MI. So it is related to an inadequate blood supply to the heart. That is correct. Also, Nicole, I see your addition there. So what's happening is, what it is ischemia. So which means that the heart muscle cells are not getting enough oxygen. So the difference is whether or not the person is going to experience these issues at rest. So typically, if the person has atherosclerosis and they have that vessel that has a plaque in it, that means that there is less blood flow through that vessel because it has a decreased lumen. There's just less space. So at rest, I might be able to get enough oxygenated blood to my muscle tissue, and so I don't feel the pain of not having enough oxygen. If I increase activity, it could be that this area where there's narrowing, I'm not going to get enough oxygen to the cells because they're going to need more oxygen if I'm being active. But then if I stop and rest again, I'll go back to being able to meet my oxygen needs. So that's the big difference between stable and unstable. Unstable angina can be brought on by some kind of stress, but doesn't go away with rest, or it can actually come up to you, start up, even though you weren't stressing the body at all. So, and it could be that even it doesn't mean that it's completely blocked. It could just be it's blocked enough that even at rest, you can't recover or get rid of the buildup of lactic acid, and you are starting not to meet those needs. Or it seems like unstable angina, but you're actually developing or you actually have an MI or complete blockage. Maybe there's a clot there or something, so there's not blood getting to the heart muscle. People can have silent angina or even have a heart attack and not realize it. And this is especially common for diabetics, because just like diabetics will lose sensory nerve function, in their feet and legs, where they can get an injury and not know that they have the injury, they can have sensory nerve dysfunction to their heart too, to the area that would feel or get triggered by the ischemic pain. And so they might not realize it. Prince metals is a different type of angina that's related to vessel spasm and not atherosclerosis, but we're not really focusing on that one. But just in case you see that term, that's what it means. So a heart or a person that is experiencing angina or myocardial infarction is a heart that cannot take work at all. They're not getting enough oxygen at rest. I cannot increase the workload for this heart without the person experiencing more pain the treatment is to get rid of all work of the heart, to try to make it easier for the heart to function, to decrease oxygen demand of the heart. So just like when we talked about heart failure, we talked about preload, afterload, and contractility. Since those factors determine work of the heart, those are the same things that we will try to target when we're trying to target angina or MI in terms of medications. And so if my whole goal is to be sure that the heart is expending the least amount of oxygen, then everything I'm going to do is going to take away the work of the heart as fast as possible. So I want to bring the blood pressure down and slow the heart rate and reduce contractility, at least until I fix whatever is going on. So, because then the heart is working less. And that is why metoprolol is actually the best medication to give in this setting, whether it be angina or an acute MI, because it's blocking beta receptors on the heart, which means it blocks heart rate and can affect the strength of contraction, and will also work to lower the blood pressure in this way. So I will take away afterload and decreased contractility, and so it's very good medication in the setting of angina. And diltiazem is too, and except that diltiazem is a different type of calcium channel blocker which affects the heart itself to slow the heart rate and potentially reduce contractility. I would not give nifedipine necessarily, because that could cause reflex tachycardia, which increases the work of the heart. So metoprolol is the key for us, is that because it brings afterload down and contractility. So previously, when we were talking about decreasing preload, we talked about using a diuretic, because if preload, P for P, if we get rid of fluid, then we can decrease the work of the heart. However, we don't have time in the setting of angina or MI to wait for the diuretic to start to work. We don't have 6 hours to wait for fluid to be pulled off. So we have to do this a lot quicker. And the best way to reduce preload is to use nitroglycerin. So nitroglycerin decreases venous return to the heart. So instead of pulling the fluid off and having the person urinate the fluid, we are going to hide the fluid by hiding it in veins. So oftentimes, and you may have heard when people talk about nitroglycerin, they're talking about it does have some action on arterial walls, so it will decrease blood pressure. It does vasodilate coronary arteries, which does help deliver oxygen to heart cells. But its main action in terms of treatment of angina and heart attack is actually venodilation. It dilates veins. And by doing that, decreases the return of fluid to the heart. So it's a very, 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 very efficient and fast way to hide fluid. So that's why nitroglycerin works very quickly. I can give nitroglycerin in many different ways. I could give it sublingually as a treatment for acute chest pain. I could give it IV for someone who has unstable angina or myocardial infarction. Or if I have a patient that has chronic angina in which they experience angina off and on frequently, then I can try to prevent angina from happening by giving them a daily medication, either orally or transdermally. So the most common side effects of nitroglycerin are headache, but that's not a reason to stop the medication because it really works. However, I just need to let the patient know that that's a definite possibility that they'll probably experience a headache. Because I'm decreasing venous return to the heart, and because I have the potential to decrease, blood pressure, that's going to happen. I'm going to have hypotension, and it could lead to reflex tachycardia, which is another reason why when someone has unstable angina or heart attack, it's a really good idea to give them metoprolol, because metoprolol stops that effect of reflex tachycardia. Because reflex tachycardia is the body's compensation for a decrease in blood pressure. Epinephrine and norepinephrine will be released and will interact with beta receptors on the heart to increase heart rate. But if I have blocked the beta receptors, even though that has occurred, even though I have released epinephrine, norepinephrine in response to low blood pressure, I cannot bring the heart rate up because those beta receptors are blocked. The other issue is when you're taking nitroglycerin on a daily basis, you can develop tolerance, especially to the topical nitroglycerin. So anyone who's on topical nitroglycerin will have to have time periods where they are off of the medicine, and usually that's done at night. So, excuse me, before we go to lunch, this is a very important part of the information about nitroglycerin, is the proper instructions to a patient who is going to have a PRN supply of nitroglycerin for chest pain use. How exactly to go about using this medication. There definitely will be questions about that on the exam. So oral nitroglycerin are very tiny little pills that are stored in a small white bottle. They have to be kept out of direct sunlight, and they should not be exposed to heat. But they need to be readily accessible for the patient. So there are, you might see in different classes, like you shouldn't keep them in your pants pocket or something close to your body because your body heat could affect them. But they do need to be close to you. I mean, a purse works okay, or some kind of other bag that the person has. But you don't want it to be stored like in the back of the sink, because it's not there when you need it, and you're going to have to expend effort to get it. So at least think to yourself at a good place for that little bottle to be stored. Sublingual medication is given under the tongue, and the whole point is I want the medicine to absorb into the blood vessels underneath the tongue so that it works fast, that I decrease absorption time. So I don't want the patient to swallow it. So if someone is getting a sublingual medication, they should not be drinking it all, because they might actually swallow the medication instead of letting it absorb into the bloodstream. So anyone getting a sublingual medication like nitroglycerin should not be given anything to drink until the medication is completely absorbed. Additionally, and put stars around this, if the patient actually has unstable angina or a myocardial infarction, they're going to need a procedure, which means they should be NPO. So we really don't want to offer this person anything by mouth anyways. Okay, so we properly stored it, and we taught the patient how to take the medication so they get the most of the medicine. Now say the patient is experiencing chest pain. The first thing they're going to do, especially if the chest pain occurred when they were being active, is rest. Take a minute, sit down, catch your breath. It could be that you were moving around. Second, give yourself the first sublingual nitroglycerin, and wait 5 minutes. Because some people have chronic angina and they're going to need to use PRN nitroglycerin now and again, and it doesn't mean that they have unstable angina or have a myocardial infarction. And so you don't have to call 911 right away, because it could be that rest and the first nitroglycerin will take the pain away. If at the 5-minute mark the patient's pain is unrelieved or they still have pain, then they should call 911. If the pain is gone, then they're done. They might have further instructions from their own provider, like inform us if that happened, or it's happening more than 2 times a week, or something that has been set up, or the instruction might be, okay, that means the rest of the day you have to take it easy, something like that. But they don't have to call 911 if the pain goes away. If the pain is still there, the likelihood that this is unstable angina or an MI has increased, and so they do need to activate EMS. And then they're going to take their second sublingual nitroglycerin and wait another 5 minutes, and then they can take their third sublingual nitroglycerin if the pain is still present. After that, even if EMS has not arrived, because it is really dependent on what location you're in, how fast those services are, you cannot take a fourth one, because at this point we don't know what the patient's blood pressure is, and we could end up causing them to have a syncopal event or some other problem when they're by themselves. So you're only allowed to give yourself 3 in a non-monitored patient community situation. So while they're waiting, they cannot take another one. So hopefully in that time period, EMS has arrived. Because the best thing we can do if they're having unstable angina or an MI is get them to the cath lab so that we can see if we need to do a stent or open up the coronary artery that isn't, that's blocked, not working properly. There is a set time, the American Heart Association's time from the onset of chest pain to going to the cath lab and having an intervention or reestablishing blood flow is supposed to be 90 minutes tops. A lot of ERs have set the benchmark that from the moment you enter the ER to the moment you entered the cath lab should only be 30 minutes, which is what, like the hospital I work at, that's our gold standard. But the real standard that's been set by the American Heart Association is 90 minutes from the time of chest pain to the cath lab, because time is heart muscle. So the longer you take, the more likely the larger the infarction will be. So
I have a question.
Yeah.
So if that question was on the test, would the answer be 90 minutes or 30?
90.
Because I know that's the one you said you differ with Mick.
Yeah. So I put 90 because I don't want you guys to get messed up. It really has to do with the wording, because the American Heart Association says, she warned us. I know this happened, so I'm just gonna go with it. It has to do with the wording. Once you start having chest pain, to the time that you get to the hospital, you activate EMS, get to the hospital, get the right people involved, is the American Heart Association standard is 90 minutes. You will see in the ER that the time from door of the ER to cath lab is 30 minutes. But there's other things that happen before then. The person had to activate EMS, the people had to get there, and then they have to get to the hospital. So I will do 90 minutes just because I don't want anyone to have any trouble with anything. That's funny that she warned you guys, though. So I will word it in terms of the American Heart Association, not in terms of door to lab. Okay, so if the patient gets to the emergency department and they're still having, maybe the chest pain is less, but they're still having the same amount of chest pain, they're active chest pain, the patient is usually started on IV nitroglycerin. And this will help until they can get to, hopefully, intervention. So when you're giving IV medication, IV nitroglycerin, you have to be careful. There's special considerations with IV nitroglycerin. It's a glass bottle, meaning that it doesn't collapse like a plastic bag will when you're giving it. So you have to use vented tubing. I'll just say this and then we'll go to lunch. So if this is the spike and this is the drip chamber and then that's the tube, normally that's fine for plastic. For a glass bottle, you have to have a vent to allow air to come out. Otherwise, the medication will stop flowing. So it has to be vented. And for nitroglycerin, it also has to be coated with nitroglycerin. So it's a special tubing that's used. So from there, we'll take our break. So we are on a break until 1 p.m. because this is our lunch break. So I'm going to